Hi everyone, thank you for listening in. I'm Naveena. I'm currently a postdoc at Harvard University. I'm excited to present our study conducted in collaboration with Noura Health, which looks at their intervention in maternal and child health in India. Noura works across 8 states in India. As part of their maternal and child health program area, they focus on behavior change education to support new parents with critical information on key health practices that prevent complications and what to expect in pregnancy, delivery, recovery, and parenting. They train health workers at the hospitals they partner with to conduct patient education sessions and provide them with locally tailored educational materials. They also support a post-discharge WhatsApp service that continues sharing information and allows caregivers to ask questions that are answered by medical support executives or MSEs who are trained nurses. Increasingly, similar information services across the global south are scaling, Mom Connect in South Africa being a popular example. In approaching this study, we were curious how widely available information services are newly shaping paid and unpaid care work in health systems. And it's by looking at an intervention at scale that we were able to see not just how the intervention was designed to function, but also how it was situated and appropriated in a larger public health system with its own gaps in delivery of care. To make sense of how the intervention was situated and appropriated compared to its intended goals, we turn to Michelle Murphy's notion of unsettling care, which pushes us to consider how care is non-innocent and has specific meanings in different historical contexts. By looking at analyses of maternal and child health as a development project under the forces of colonialism and neoliberalism in India, we see the structural issues that behavior change and health interventions will need to contend with. Issues raised by feminist scholars include the equating of women's health with maternal and child health through the narrowing of policy and funding on the latter. They also critique the privatization of healthcare and focus on optimizing limited resources in public health, which shifts the responsibility of ensuring good health onto individuals and families. Our work looks at how health interventions fit into this picture by attending to how information services, often intended to support behavior change, might still run up against these structural issues in their implementation and use. Our methods consisted of analysis of a log of questions received since the launch of the WhatsApp service, as well as analysis of individual chat logs from the WhatsApp service. We also remotely observed a hospital-based patient education session and MSE's work responding to questions sent to the WhatsApp service to get a sense of work practices. We also conducted 13 interviews with MSEs and other NGO staff involved in design, medical expertise, implementation, and research to understand organizational priorities and experience with implementation of the intervention. And finally, we interviewed 9 parents who were registered users of the WhatsApp service to understand distribution of caregiving work within the family and experiences with the intervention. In our findings, we explore how care is situated within 3 sites of the intervention: in district hospitals where patient education sessions are held, in the human labor behind the WhatsApp service, and in the daily lives of families, and how it interacts with the material realities of healthcare in India. We start with the patient education sessions in hospitals and the necessity of reevaluating care work to make the intervention work. At the hospitals that the intervention is deployed in, health workers are provided trainings and to conduct patient education sessions, and are provided tailored materials such as flip charts to aid them. Healthcare workers conduct the sessions on top of their usual responsibilities. The sessions are also a key point of discoverability for the WhatsApp service, contributing to its increasing adoption. Eventually, the NGO aims to shift standards of care at hospitals towards more effective patient education, for example, demonstrating the importance of budgeting for training health workers to conduct effective sessions. In talking to the implementation team, which supports hospitals in holding the sessions, we were told that the trainings, materials, and larger goals of patient education are important to health workers. However, the implementation team also worked hard to make health workers feel respected and have a sense of ownership over the program. For example, an implementation team member told us, and we'll call them madam, we'll take them to lunch or soft drinks. In hospitals, what happens, the administrators don't treat them like this. They used to scold them, blame them. So we see how functioning in the context of overburdened and undervalued workers requires not just a well-designed intervention, but also active effort to mitigate the relations workers are subject to. In the paper, we also discuss how improving working conditions is also what motivated MSEs to look for alternative career paths to nursing, namely working on the WhatsApp service, emphasizing the effect of working conditions on labor flows. We now look at the labor of MSEs behind the WhatsApp service to offer a good experience for families and how families' relationship to the larger healthcare system complicates this work. A significant part of MSE's work was producing the WhatsApp service as one that is trustworthy and reliable, and we describe the range of work such as making calls, building rapport, and minimizing response time that help in this endeavor. However, what complicated this work was how the WhatsApp service was introduced to families. Often, families encountered the WhatsApp service via health workers or from someone they know, but MSCs in the medical team shared that some families might see only a poster and then associate the number with the hospital itself. For example, a doctor on the medical team told us where the intent of the service is not communicated well enough, people assume it's that hospital's number, so then they associate us with them, and so then there's no trust. A challenging experience at the hospital could then lead to further frustration with the WhatsApp service. For example, the doctor shared the example of a person who was unable to fill a prescription at the hospital and turned to the WhatsApp service, only to be further frustrated that that was not something that the service could provide either. At the same time, families also turned to the WhatsApp service to fill gaps in in-person care. For example, families messaged asking for interpretation of lab reports, prescriptions, or doctor's notes, indicating little opportunity to fully understand these in the hospital itself. There were also a number of more emergent situations that families messaged about through the service, including uncertainties about being asked to pay the hospital despite having access to public health benefits, or needing emotional support and understanding what to expect in confusing emergency situations. In one example, an MSE fielded messages from a woman who had received distressing news regarding her pregnancy and was experiencing long wait times and a lack of access to her medical records. The MSE counseled her over the phone and explained that the mother felt very happy because we spoke to her. The hospitals don't even care, and especially in this time of the pandemic. So in such cases, we suggest them what is the next process, what will happen. And so we see how the WhatsApp service is simultaneously shaped by perceptions of the larger healthcare system, but also in turn is supportive in that it fills in gaps in the healthcare system. We now look at caregiving work among families and their engagement with the WhatsApp service, attending to the experiences of fathers and mothers and their appropriation of the service beyond behavior change. The behavior change goals of the intervention sought to involve the whole family, including men, in healthy practices that would benefit the mother and newborn, such as promoting a healthy diet for mothers or skin-to-skin care for newborns. While fathers we interviewed did find this information useful, we found that in this particular context, due to being the sole earner in the family and needing to work long hours in occupations like driving or construction, men were often involved in other aspects of caregiving beyond the home as well, such as transportation, care coordination, and purchasing food and medicines. At the same time, the information provided by the service could also be useful in ways that were more subtle than being convinced of the importance of certain health practices. For example, one participant explained how even though he had previously known to vaccinate his children with the immunization schedule shared via the WhatsApp service, he now knew exactly what his child should be receiving at what age and could ask for the right vaccine if the health worker did not provide it. Registering for the WhatsApp service could also be a way to bridge the many ways that men could not be involved in women's health, such as men not being able to attend ANC appointments in government hospitals. Prior work has discussed the challenges that women face in care seeking within the home and hospitals. We describe how the WhatsApp service intervenes in some of these dynamics. In one example, two-way interaction allowed the service to be used as a form of advocacy by mothers. The doctor on the medical team described how a woman told the service that her family had been restricting her diet and asked that the service talk to them. In another example, we found that there had been cases of women coming to the service with questions about intrauterine devices, also known as copper teas, being placed without their knowledge. The medical team's approach in counseling the mother in these cases indicates how the informational nature of the WhatsApp service allows for triaging. She said, "I feel like we've at least been able to calm her down by letting her know what it is essentially, without her having to travel maybe 30 to 40 minutes. Taken together, while tools and information for individual behavior change have a role in strengthening health systems, interventions must also contend with the structural power dynamics that workers face in inequitable health systems. We offer ways to reframe the design and implementation of health interventions to focus on how interventions can engage with structural issues. We saw how the success of the intervention was not just about well-designed tools, but also about attending to the problems of overburdened and undervalued care work. Our findings then bring up the question of how handover to public health systems, as many interventions aim to do, could pan out. We ask whether and how the relationships that value care work can be maintained in the process. In practice, addressing this could look like NGOs framing improved working conditions as part of theories of change. Prior work on codes of conduct for NGOs also suggests directly advocating for increased numbers and capacities of workers. We also saw how the WhatsApp service did not simply elicit trust through an interactive text-based persona. More so, it was an infrastructure that was embedded within a fragmented health system, which heavily shaped how families approached the WhatsApp service in the first place. This reframing calls for going beyond considerations such as anthropomorphism. By viewing interventions like the WhatsApp service as infrastructures, this can help foreground the human labor that produces relationships. It also brings attention to the intervention situatedness within the broader healthcare system and what kinds of associations families may be coming in with. Finally, the service did not just support literacy around certain health practices within the home, it also addressed the rights that patients have to information about their treatment options, care, finances, and other aspects. Thus, the WhatsApp service addressed care work beyond the home and individual health practices. Our findings point to the usefulness of information for advocacy of appropriate care. We also saw how it can be useful in protecting one's time and financial resources. We also saw how information can help in coping and sense-making in unjust and distressing experiences with healthcare. Attending to this aspect of information may be especially important for addressing broader definitions of women's empowerment and the challenges of navigational work. Thank you for listening.